Asthma is one of the most common conditions in children, but it's also one of the trickiest to diagnose. Label a child too quickly, they may end up on unnecessary treatment, miss the diagnosis, and you risk a life-threatening asthma attack. Most GP trainees lose marks in the SCA because they don't take a focused history. Hey friends, my name is Erwin. I'm a GP based in the UK, and I've helped hundreds of GP trainees pass SCA with confidence. Today I'll walk you step by step through how to diagnose and manage asthma in children. We'll cover 3 case examples, so in your exam you'll know exactly what to say and how to score well with confidence. Tom is 8 years old. He wakes up at night coughing, he gets breathless playing football, and he's already missed school. His mom is worried. Is this asthma? NICE guidelines emphasize a structured clinical history and objective tests to confirm the diagnosis wherever possible. When a child presents with possible asthma, here's what we need to ask. The nature of symptoms: wheeze, cough, breathlessness, chest tightness. The pattern: are symptoms worse at night, early morning, or seasonal? Do they vary day to day? What are red flags? Intercostal recession, use of accessory muscles, if there's any sucking in the chest, lethargy, drowsiness, faltering growth. What are the impact? Miss school, reduce exercise. Let's talk about the risk factors, atopy being one of them. Patients who suffer with eczema, allergic rhinitis, conjunctivitis, or any food allergy. What are the triggers of asthma? So viral infection, cold air, pets, or even smoke. Inquire about environmental factors, so parental smoking, including e-cigarettes, damp, mold, or air pollution. Consider family history of asthma or atopy. Inquire about significant medical history, such as visits to the emergency department, hospital admissions, or requiring ICU. Pro tip: a normal examination doesn't rule out asthma. Be guided by your history. When taking a history, it's important to keep an open mind. So think about your differential diagnoses, such as viral respiratory tract infections being very common in children, bronchiectasis, inhaled foreign body or recurrent aspiration. This usually presents with a sudden onset. Chronic upper airway cough syndrome, i.e. postnasal drip, and even cystic fibrosis. Let's apply this assessment to Jacob, an 8-year-old boy. He's been coughing at night 2 to 3 times a week and gets chest tightness after playing football. He's missed school, his mom has eczema, and his chest is normal on examination. What's your working diagnosis? This history is suggestive of asthma, but now we need objective tests. What is a first-line objective test recommended to confirm asthma in children aged 5 and over? Is it peak flow diary, fractional exhaled nitric oxide, spirometry, or skin prick testing? Please write your answer in the comment section. Pause this video and write your answer before you continue watching it. The correct answer is fractional exhaled nitric oxide. Do you know what's a FeNO level of parts per billion or more is considered supportive of an asthma diagnosis? Is it 15, 25, 35, or 45? Pause the video here and write down your answer in the comment. The correct answer is 35 parts per billion. If FeNO isn't raised or isn't available in your practice, consider a spirometry with bronchodilator reversibility. Looking at this volume time graph, you can see that there's a variation between pre-bronchodilator and post-bronchodilator. Do you know what change in FEV1 of the bronchodilator use confirms asthma? Is it A, B, C, or D? The correct answer is C, 12 or more percentage increase from baseline, or an increase in FEV1 of 10% or more of the predicted normal FEV1. If spirometry is not available, use a peak flow diary for 2 weeks. The best of 3 measurements should be used each time. Variability of 20% or more supports asthma. If you're still uncertain, consider checking allergy tests, IgE, and blood eosinophil level. Jacob's FeNO level comes back raised, and we can confirm that he's got asthma. So let's talk about how you explain this to the mom. Acknowledge mom's worry. Explain asthma diagnosis in simple terms, such as airways sensitive, get narrow, inhalers keep them open. Involve the parent in the decision making, so use shared management. We can try this treatment for a few weeks and see how Jacob responds. Pharmacological management for children aged 5 to 11 years old is twice daily pediatric low-dose ICS and a short-acting beta agonist. If the symptoms are not controlled, the next step is to assess ability to manage MOD regime. What is MOD? It's a maintenance and reliever therapy. It consists of an ICS, inhaled corticosteroid, and formoterol combination inhalers. So you have 2 medications in one inhaler. If the child can manage MOD regimen, then you can consider pediatric low-dose MOD. However, if the child cannot, then consider adding a leukotriene receptor antagonist to the twice-daily pediatric low-dose ICS and SABA. It's vital in the SCA that you don't just prescribe a medication, but also think about checking the inhaler technique, use an age-appropriate spacer, provide a personalized asthma action plan, and educate parents and liaise with school. It's vital that you discuss the side effects of medication. Some parents may be worried about inhalers which contain steroid, so it's important to discuss the pros and cons with the parents, explaining the need for rinsing the mouth after using a steroid inhaler. It's really important to address smoking cessation advice. For example, if you've got other members in the family smoking in the household, and provide realistic safety netting advice. What are the symptoms or signs that the patient or the parent needs to look out for? Now let's meet Sophie, age 4. She has recurrent wheeze, mostly with cold. She's too young for reliable spirometry or pheno. In this age group, objective test is rarely possible. The guidelines suggest a trial of low-dose ICS if the history suggests asthma with regular review. Consider an 8 to 12 week trial of twice-daily pediatric low-dose ICS as maintenance therapy, with SABA for reliever if symptoms at presentation indicate the need for maintenance therapy, for example, interval symptoms in children with another atopic disorder, or the severe acute episodes of difficulty breathing and wheeze, for example, requiring hospital admission or needing 2 or more courses of oral corticosteroid. When the child turns 5, if they're still having symptoms, that's the time to attempt objective testing. Offer reassurance about monitoring that some children do improve with age and grow out of it. Case example 3, child over 12. You're the GP seeing a 15-year-old boy, Daniel, with asthma. His mum accompanies him for a review. Dr. Daniel's asthma has been playing up again. He's been using his inhaler more often, especially when he's playing football or when the pollen is high. In the past medical history, you can see that Daniel was diagnosed of asthma at the age of 7. He's also got a history of allergic rhinitis. Mum suffers with eczema. He's been previously prescribed salbutamol inhaler as a PRN basis and was previously on a low-dose ICS but stopped as he felt better. Currently, he's been using his reliever inhaler 3 to 4 times a week. Wakes once or twice a week at night with cough, wheeze. He's quite breathless during activities when he's playing football. Exploring environmental factors, you found out that he lives with his parents, no smoking at home. The concern from Daniel is that he's worried about being the wheezy kid at school. Mom wants something more reliable to prevent flare-up. Question for you. What is the most appropriate first-line management step for Daniel at this stage? Is it restarting the low-dose ICS daily and continue salbutamol pre-RN? Offer ICS formoterol as needed? Prescribe high-dose ICS daily? Or start leukotriene receptor antagonist? Pause the video here and write down your answer. The correct answer is to offer ICS formoterol as needed. This is the anti-inflammatory reliever therapy, also known as AIR therapy. The key point is for children aged over 12 or equal to 12, AIR therapy is preferred over SABA alone. So how are you going to explain this to the child? Daniel, at your age, the recommended first step is a combination inhaler that contains both a preventer and a reliever. You can use a Symbicort when you have symptoms. It works quickly to open your airways, but also protects them long term. This is called anti-inflammatory reliever or AIR therapy. Next question. If Daniel continues to wake at night twice a week despite AIR therapy, what's the recommended next step? Switch back to salbutamol only, prescribe oral steroids, escalate to low-dose MOD with ICS formoterol, or add theophylline. Write down your answer in the comment. The correct answer is to escalate to a low-dose MOD with ICS formoterol. The same medication that was prescribed under AIR therapy can be used more regularly as a MOD therapy. So instead of using it as required, the child can use it twice a day. It's very important that you review the patient and step down the management so that the lowest dose of steroid is given to the patient. So once controlled for at least 3 months, consider stepping down to as needed AIR therapy. and emphasize a step down as part of long-term safe management. If you find this video useful, you might want to watch the next case demonstration on breathlessness. Click here and I'll see you on the other side.